another lesion again. And you can see it moving on the right, on the left you can see it pause. So this is in the duodenum. The question is, where in the duodenum is it? That's the first question we're going to discuss, about how to judge whether something's in the bulb or in the second part. Also very important if you're resecting polyps in the duodenum, or you're even thinking about it, or even if you're referring to somebody else to resect polyps in the duodenum, that you think about including the following information: size, potential of invasive disease, and relationship to the major structures, which include the major and minor papilla. So let's start from the start. You've seen the lesion. We come back, and it's very nice to get this sort of view when you come back on the pylorus, right? So I'm on the pylorus. I see the lesion in distance, kind of falling out a bit, but you see the lesion at the 3 o'clock. So it's not in the second part. It's in the bulb, on the junction of the bulb and the second part. That's the first important observation here. Okay, and then we're going to say, all right, we're going to go to the second part. So as you know, that's a bit of anti-clock on your left hand, and then a bit of clockwise as you pull back on the shaft. Many other videos on that if you want to look into that more. Next thing, locate the major papilla. So you might notice that this cap is a very short cap. It's just sneaking off the edge of the endoscope. That's on the scope, but it does really allow you to pull back, usually in the, if you get the scope straight in the 11 o'clock orientation, to pull back and visualize the major papilla, right? And then get a view of it, pause that view. Just 1 second while we stop, take the phone out here up in my front pocket. You have to cut this off the video, Karen. All right, we restart. So in the, usually as you pull back, you end up seeing things in the major papilla will be, if you're in the neutral position, it will be in the 11 o'clock orientation. We can take a paused image and we can say that this looks completely normal. Very important. And then if you really want to go for gold, this is not a magnifying endoscope, but it's right now, you can examine the papilla also using BLI to make sure you see nothing irregular, and we don't. We see a normal morphology papilla. Here, by the way, often people worry about this sort of tail of the papilla as being an adenoma. This is not. This is a normal appearance. Okay, and then we're going to characterize the polyp. So first question is, where is it? Well, we already said it's in the bulb. As we come back, to maintain your position in the second part, add clockwise torque. So I'm adding clockwise torque with my right hand now as I come around a bend to visualize the posterior wall of the duodenum as we come round from the second to the first part, right? And I come immediately on this polyp. So it's at the junction for sure, and as we come round the posterior wall, it's back on the, I would say, more on the side of the bulb, but it can be described as the junction probably between the two. And then we want to characterize this thing. So main question, if you're out there seeing this for the first time, is don't send it to a surgeon. When I started doing endoscopy, I was also doing that, and of course maybe the surgeon likes that, but the patient does not need surgery. This is a 78-year-old patient with multiple comorbidities. Therefore, the treatment of this is either don't treat it, or do it with some sort of therapy which is not risky. And the other major question is, does it contain cancer? So let's apply the general approach of, okay, we don't have a magnifying endoscope, but we want to see the surface structure. So for that we need a characterization mode, which BLI is 1. We gently pull back on it to try and immobilize it, and we get a frozen view, where we can have a discussion about whether it's regular or irregular. And I think that you might say, well, there's kind of 3 parts to it, but it's overall pretty regular. You also might say to me, well, you didn't see behind that fold very well, and so I agree that that is a very good use of a cap. And so as we push on it with the cap, we can pivot the lesion over maybe and have an idea about what's going on at the back, but not a great idea. So if you want a better idea, then there is only one answer to it, and it's immersion in water or saline, depending on what you want to do. I don't know what sort of pressure we've got on the water pump here. Yeah. This is water, I think, not saline. So
it's saline.
It's saline, sorry. So we get a lot of bubbles because we're using a system which is with large bags of saline for if we want to do saline immersion. But if you come back, then we can just go back in there because we fell past it here. I think we're on it now. And this thing will float up at you. You get a natural magnifying effect of the saline. Maybe water would be better for this. And you can see the back. We don't have magnification, so there's no point in trying. We maybe could go a little bit less with the pressure. That's great. And now we really can see the back of it. And if we freeze it, I don't see anything irregular here. So this is for me, a standard tubular adenoma of the duodenum without risk of malignancy, located at the bulbar duodenal overhang, the junction between the first and second part of the duodenum. I lost my English for a second there, which is quite concerning for me personally. And then not related to the major structures. And you might say we didn't mention the minor papilla. That is a good point. The minor papilla sits a little bit more cranial and a little bit more superior than the major. And so if we find the major again, and I think we've just gone back past it, we come back in this orientation, we should find it again. Here it is. So if you're looking for the minor now, think, okay, I need to go clockwise and back a bit. Okay, let's do that. Let's go clockwise and back a bit. You don't always see it. It's not always visible, but it should be around about here if we're going to see it. I'm not seeing anything, and therefore we're not worried about that. We're certainly not worried about the association of this lesion with it, which is the main concern, if you have a pancreas divisum, for example. Okay, so I hope that's useful. I hope it's interesting. This is how you assess a duodenal lesion. We'll go ahead and resect this with cold snare, piecemeal, because of the comorbidity of the patient and because that's what we discussed with them in the consultation. Thanks for watching.